Cool. Okay. Thanks everybody for joining the July APAC community call. We have two speakers today. Cynthia will first present a review of EMA's selected RWD, real world data studies. And then we'll have Jason to share his experience and do a quick recap of the recent OHDSI Europe Symposium that took place, I believe, almost 2 weeks ago. So we've did a flip of the agenda than our usual. So we'll have the presenters first share first, and then if we have any time, I'll quickly go through some news from the global side as well as our usual APAC news. So without further ado, I'll hand over to Cynthia for her session.
Hi, everyone. Let's see. Let me come on. Hey there.
Cynthia.
Okay, it's good evening from me here in Massachusetts, where it's 11 p.m. I'm going to share my window in just a moment. Let's see, and then I'm going to see if I can go to presenter mode. Can you see that?
Yes.
Okay, great. Yeah, so I'm going to talk a little bit about a few of the studies that have been done in Europe to support the EMA's decision making. I just wanted to give a little background that I got interested in this work through some consulting work that I was doing for Health Sciences Authority. And they began to think about using real-world data following the launch of the Ministry of Health One Patient, One Health Record, or NEHR. And HSA thought that they could use the EHR to strengthen its work to monitor the safety and effectiveness of health products. And other institutions were interested in how to then link that with pharmacogenomic information. And so we formed a consortium, submitted that to the National Medical Research Council, and we were funded for this project, which was known as SAPPHIRE. And the HSA was responsible for the aim to establish a national active surveillance network to leverage electronic medical record capabilities to identify patterns and early indications of EHRs. And just wanted to show a picture of that team. So sure many of you know Shimani, and perhaps you met Peishan and Huixin. They were at the APAC, OHDSI APAC meeting in Singapore last year. So when we got started this work, we were, of course, following what we thought was a good model that FDA was pursuing at the Center for Drugs and Evaluation. And their model was very similar in concept to OHDSI in that they wanted to have a federated network and that they would standardize their data model. So in the same way that OHDSI does it, they would send code to all their data partners who had standardized their data to the Sentinel model, and then send back statistics to the Central Coordinating Center, which would then write the report for the FDA. And primarily, they were relying on claims data, which are already pretty well coded. So one thing that we learned was that they did not control the vocabulary. So they had very standard tables and they standardized the column headings, but not the vocabulary. So when you go to EHRs, which are much messier, and maybe many of them don't adopt a coding system, then it was more difficult to use. The other thing is that while they were very transparent in the codes that they used, they were written in SAS, which is a very expensive statistical analysis software package with a pretty costly annual fee. So we became familiar then with the Observational Medical Outcomes Partnership. And what we liked about it is the things that you all know about is that it handles many different data types. So besides claims, EHR, registry, surveys, and the big thing for us was the vocabulary was standardized. And as you've seen over the years, they have increasingly created standardized analytics and standardized phenotypes. So when we learned about OHDSI, we also knew that Aju University was at the leading edge of OHDSI. So we invited them to come down and help train us. So in January of 2018, Professor Ray Woong Park and Chan, whom you all are very familiar with, and Dr. Dahishin came and they showed us, how the basic steps of an ETL. And so several months later, we had the opportunity to get data from Kutupwa Hospital, and we knew that a fairly straightforward program was the treatment pathways that had been published in, I think it was maybe PNAS a couple years earlier, and there was a big emphasis on diabetes in Singapore at that time. And so what we did was we transformed the data, and we really only needed 4 tables. That is the patient table, the visit occurrence, condition, and drug exposure, just at the ingredient level. And so we had a summer intern. Let's see, are you seeing this? Let's see. Yes, Haroon Chahed. He was a rising junior, a computer science major. And so together, he and I did this ETL of those 4 tables, and we were able to run the treatment pathways. And what was so fascinating was how different the pattern is in Singapore. And one thing I want to just mention is now that the data in the trust database or the trust repository, I believe all of those tables have been transformed. And now the treatment pathways is part of the Hades package, the standard analytics. This could be done fairly easily for all of Singapore, not just KTPH, but also for other diagnoses. But so that was just a little background of how I got into it in Singapore and some thoughts I have about how one can move forward fairly quickly in Singapore to use the OMOPT data in the trust repository. So on to Europe. In 2018, the IMI, it's called the Innovative Medicines Initiative, which is like the NMRC in Singapore or like the NIH, I guess, in the US. They funded a program called the European Health Data and Evidence Network, EDEN. And the way this worked was they gave out money to data owners, 100,000 euros to convert their data to the OMOC Common Data Model. And there was an application process to get this money. They received 563 applications, and they awarded by the end of the program, 187. And by the end, you can see they had, quite a lot of partners from Spain, Italy, and UK. And then the next most common countries were Belgium, Portugal, and Germany, and Netherlands, and then so on and so forth. So they had, I think, 29 countries, 187 databases. And then this became the foundation for the Darwin EU program. That stands for Data Analysis and Real-World Interrogation Network. And so this was similar to what Sentinel was trying to achieve in the United States with the FDA. So the EMA was going to rely on the OHDSI network at Erasmus Medical College to tap them to answer questions to help them with their regulatory review work. And they had a very ambitious, let's say, submission where they said that this is with a number of studies they would deliver per year, and they categorized them by whether they were routine repeated analysis, off-the-shelf studies, complex studies, or very complex studies. And I think 2024 was their third year, and this is their target, was to do 6 to 12 routine repeated analyses, 25 to 30 off the shelf, and 12 to 18. So you can see this very aggressive schedule to our timetable to deliver studies. And so this has been why there's been such a big push towards standardized analytical pipelines. And at the European Symposium, it was announced that Darwin EU has conducted 47 out of 59 real-world data to real-world evidence studies for the EMA in the last year. And the average turnaround time was just 4 months. And then at the European Symposium, Patrick Ryan challenged everyone to see if they could reduce that turnaround time to 4 weeks or 4 days, or perhaps even 4 hours, which sort of made all the Darwin EU people have kind of like a heart attack to think that they could do it in such a short time. But anyway, let me move on to some of the studies. So a few months ago, I presented 3 studies to HSA. Darwin EU study suicidality following doxycycline exposure. They'd also did a study on the effectiveness of COVID-19 vaccines on severe COVID-19 and post-acute outcomes of SARS-CoV-2 infection. And then not a Darwin EU study, but an EMA study, which I think will be of great interest to you, is the association between exposure to liraglutide, which is a GLP-1 receptor agonist, versus active comparators and the risk of acute hepatic injury. And due to limited time, I'm just going to do 1 and 3 today. So Nicholas Hunt presented this at the European Symposium. It's a multinational network cohort and self-controlled case series study of the effect of doxycycline on the risk of suicidality, depression, and anxiety in patients with acne. And so this is the background. Doxycycline, it's a tetracyclic antibiotic, and it's widely used for treating acne, upper respiratory tract infections, sexually transmitted disease, and rosacea, which I think is also a skin condition. And the EMA had received some case reports about association between this drug and suicide. And so they commissioned Darwin EU to do this study, which is considered a complex study. So they took this to, so the objective was to estimate the risk of suicide-related events, anxiety, and depression during doxycycline use for treatment of acne, but they actually ended up looking at treatment of all of these conditions. So here is there, the primary one was a causal association between the use of doxycycline and suicide. And then does the association and the alternative treatments that they looked at were empagliflozin, dapagliflozin, and sitagliptin. And so the inclusion criteria was, greater than 365 days of recorded medical history prior to the index date. And it was a new user design with the liraglutide or the comparator drug. And they looked at any indication for the use of these drugs or specifically for type 2 diabetes. Exclusion criteria was history of the outcome prior to the index date, and they had 2 databases, the IQVIA database from the UK and IQVIA from Germany, both approximately the same time period, but there was no sample priority sample size that calculation, at least in the study report. And so, as you know, this very common thing is to do the large-scale propensity scoring. So before matching, they had 14,668 liraglutide users, and sitagliptin is much more widely used drug, so they had 113,350. But after matching, they had 8,506 in both these drugs. And so you can see this figure, the scatter plot of the standard difference in means, where there is really a large difference among the different covariates that they tested. And then after matching, it's all well below 0.1, which is the usual threshold. And they listed in their study report all the diagnosis codes that are the OHDSI standard vocabulary codes. They use diagnosis codes only, so no liver function tests. And so these were the ones that they included, and they excluded many lower level concept IDs. If you go to the study report, you'll see all the lower level concept IDs that they excluded, such as, alcoholic liver damage or Lipitor hepatotoxicity. So I think for those of you who are working on the acute liver injury test, this is an interesting report to look at what exactly they did. You may want to compare. So it was a new user cohort, any indication or type 2 diabetes with follow-up 90 days, and they did a Cox proportional hazard ratio with sensitivity analysis of follow-up for 180 days and 365 days. And then I think they also did ones with type 2 diabetes patients who are on metformin with liraglutide added as second-line therapy. So briefly, there were a lot of tables where they just did not have more than 5 cases, and so the standard OHDSI criteria is then you don't do the analysis, right? Because with fewer than 5, there might be a risk of patient identification. And so the one interesting result was when they compared sitagliptin and liraglutide, that when for all indications, they had 25 events for sitagliptin versus only 10 for liraglutide, and in those 8,000 subjects. And I guess it turns out, let's see, the number of person years of follow-up was in the 7,000 range. So that was very significantly statistically significant hazard ratio of 0.4, and the confidence interval did not include 1. But when they limited their analyses to patients with type 2 diabetes, then the number of events for the sitagliptin group dropped down to 5. And I thought that was really interesting, is that are there a lot of, I guess, sitagliptin users who are not only treated for type 2 diabetes? And then liraglutide, there was just one that ended up being removed from this analysis. So for type 2 diabetes, as you can see now, it's not statistically significant. Let me see. Then here down at the bottom, this was for acute hepatic injury with no chronic hepatic failure, and then there's nothing statistically significant. So for me, the main takeaways was that liraglutide had fewer cases of acute liver injury compared to sitagliptin when used for any indication, and that the sitagliptin acute liver injury cases occurred mostly in patients who did not have type 2 diabetes. And then no calculation was done to estimate sample size to achieve statistical power, as had been done for the doxycycline study. And so many comparisons were not completed because there were fewer than 5 patients. So the limitations that were noted in the report was that it's a primary care database, and so there may be incomplete information on subsequent hospitalization, and perhaps incomplete linkage of patients across different medical institutions. And the data doesn't really capture patient adherence to medication. You only have, I guess, the medication prescriptions. So that's all I had to present. And so I'm happy to entertain any questions.
Thanks, Cynthia. Right on time. Does anybody have any questions for Cynthia? Thanks for sharing. Maybe a comment from myself, Cynthia. So I think the second study you presented about was sort of our motivation for the APAC study we did last year with the Singapore team, right?
I see.
Yeah. So we did a very similar study looking at GLP-1 agonists and a liver outcome. So and we also did get HSA's input during that entire process, where they actually came up with the study question and wanted OHDSI as a community to investigate that. So thanks for sharing that. Roger, you have your hand up. You're muted, Roger.
Can you hear me okay?
Yes.
Yeah. Thanks for the presentation, Cynthia. That was really interesting. Can I ask, in each case, we used the IQVIA data set. Was that typical in the European Symposium? Did you only see data from IQVIA data sets, or did it go wider than the IQVIA data set?
I think maybe Mui is a better person to answer that. And I see that she's here.
Want me to take that? So Darwin, the way Darwin works is they have, so every year they have data partners. Okay. So Darwin's objective is to bring in 50 data partners by the end of year 5. And as of right now, they've onboarded 20 data partners. And they basically, to do a study, what they go through is a feasibility assessment of all the different data assets that are available for each study. And then figure out which one's the best fit. So for any study, that's what they've done. So I guess for some of them, the IQVIA data was a fit, but then I know there are studies where the IQVIA data was not a fit. We only have 2 databases in the Darwin network. The other 18 are not IQVIA data assets.
Yeah. Thank you, Mui. That kind of explains it. I just think it'd be good to see more data sets used, because I know the IQVIA data sets are large and good quality, but I'd really like to see other data sets included as well.
Yeah, there's quite a, like I said, you can go to the Darwin website. It'll show you what all the 20 data assets are that they have. This year they're onboarding another 20 or another 10. But I do know that of the 10, they're actually also aiming for US ones too. So that they can do a comparison against EU versus US, right? So I know they're doing that.
Okay, thank you. Thanks, Cynthia.
You're welcome.
Mui, did you have a question?
I don't have a question. I just have a comment. And it's not on one of these studies, but just to bring up, like what is Darwin doing, and how they're actually using these studies. There's actually a article, or it was last month or the month before, I can't remember. They actually did a guideline change to antibiotics because of an actual Darwin study that they did across multiple data assets. So that's how EMA is actually thinking about utilizing this network, right? At the beginning, it was a lot of just understanding these diseases and figuring out what the process and the operational procedure was to actually do these type of exercises. But recently they've actually started looking at, okay, are my guidelines accurate, or should I look at real world data to even measure to test out some of my guidelines, right? So there's an example where they actually did run this study in Darwin, and as a result of it, EMA actually changed their guidelines for the use of antibiotics. So there's an article about the study is available, as well as the guideline is available now. So,
well, I have a question then for this community is, have you considered looking at the self-controlled case series design for the liver injury study that you're doing? maybe Morning could answer that. Are you there? Yeah. Hi, Morning. I see you're on.
Yes, yes. So yeah, sorry, I was cut off. Yeah. Do you mind repeating the question again?
Yeah. So one of the learnings I had from the doxycycline study was the smaller N that you needed to have statistical power. Is there any consideration of using that design for the liver injury study or for other studies that are planning, especially in smaller countries like Singapore, where there are just smaller N, and so you can achieve greater power on those questions?
Yeah, absolutely. Yeah. Compared to our like now for the next year's APEC study, we are cooperating with partners in China. So it's very obvious that compared to our counterparts in China, our N is like easily 1/10 or sometimes the 1% of what they have.
Yeah.
Yeah. So we need definitely need the statistical considerations when dealing with such a small N. And yeah, the lesson learned from how to deal with a small cohort on individual side, that would be very useful. And moving forward, I think I'm not really about statistics myself, but if someone may help to see that in a multi-center setting, how we may then collectively combining the findings from various centers, kind of in a multi-center meta study style, that we can then boost the overall power and overcoming the limitation coming from some individual sites that may have small, and that those kind of models or experience will be very helpful for like you say countries like Singapore as well, and even not just Singapore. Like I was in a meeting with some of the regional Ministry of Health in Southeast Asia. A lot of them, like Thailand or Malaysia, they already started a journey in order to see more conversion. But in the beginning, they may just try out with one hospital and so or some sort one part of their data rather than entire EMR. It's very likely that they may end up with a fairly small N to begin with in the early stage as well. So for them, yeah, all this will be relevant as well. Thanks.
So I just remembered that I failed to mention that Mui also came in January of 2018 when Aju was there to teach us about OHDSI. So Mui, sorry for the omission, but it was a real surprise, a wonderful surprise. She showed up. I guess she'd been alerted by Ray that they were there. Do you remember that, Mui, coming to HSA?
Nope. Yes, I do. I actually still have pictures of on that. But no, it's okay. It was really Professor Park and Chan and team who should take all the credit because they're the ones that were working with it. I just happened to tag along because they invited me. So
but I think that's the first time I met you, Mui. Yes. Sorry.
Cynthia, to your question on the SCCS model or the specific method,
Design.
right? It was considered when we first did the study with the Singapore team last year, but we decided to go with the cohort method first, and then if once that's complete, we would consider the SCCS model as well. So right now the study is still ongoing, and we're still in the cohort study portion of the study. So once that's over, maybe the study team will decide to further explore the SCCS model.
Do you have a biostatistician who can calculate the power for you?
Not sure. I don't think we're even doing that yet, at that phase yet for the SCCS.
Yeah. No, I mean for the new user comparator study, because maybe you just don't have the power to,
I think I'm trying to say that we haven't even explored that area yet. So yes, we will. When we do the SCCS, we'll need to consider the sample power, right? Based on your presentation.
For the new user cohort, like what they did in the doxycycline study is that they, I don't know, for anxiety, they needed something like 13,000 cases per arm. And do you even have that to get 80% power? So of course the incidence is different, and you'll have to know that number.
I don't think we've explored that yet. No.
So Chi, you have a question?
Yeah, I don't see how you can use SCCS in this situation, because you are comparing self, right, with the period when you use the medication and when you're not using the medication. Now, for
Correct.
something like depression or suicidal intent, those are fine. But for acute liver injury, I mean, it's not going to happen when you are not using any medications.
Yes, but
So,
I mean, so many of people are on polypharmacy, so you can look to see if there's acute liver injury that's occurred prior to the um, start of a medication, or maybe sufficiently outside the risk window that you think is reasonable. So they, for example, used 90 days. So if you have acute liver injury more than 90 days after a start of a drug, do you think that's, is that really likely to be related? I think it is possible, and it's certainly possible with lab results. I mean, that was something that we looked at with HSA. We did a study looking at abnormal lab results before and after drug use.
so you're saying compare one medication versus another medication during
No,
different time.
no. So you're
I
just
mean,
saying whenever
acute.
you started, say you start one of the GLP-1 receptor agonists, right? And you look 90 days before, was there any code of some kind of liver event
No, there
versus
shouldn't be
after?
any.
You don't think there would be, but there might be, you know?
Okay, guys, I love the
Okay.
discussion right now. I think it's very research oriented. I
Okay.
love the back and forth, but we do have another speaker for today,
Okay,
guys. So
sorry.
yeah,
Okay.
Okay.
Go ahead.
I'll have to stop you guys, and I'll hand over the floor now over to Jason to share his experience at the Odyssey Europe Symposium. Thank you, Cynthia, again for your presentation. Chi, if you want to continue that conversation with Cynthia, please do connect with her separately. Okay. Sorry, guys.
No
Over
worries.
to you, Jason.
Can you hear me?
Yes.
Okay. Personally, I'm also interested in the research design, like CSS, ST, and also I'm really want to discuss any possibility about using different design to or answer any questions. Okay. How much time I have?
You
Maybe I
have
will
you
use.
have the full 20 minutes, Jason, if you need. Okay.
Okay, so I'm going to control by myself, or you will help me to control the slides.
What's easier, Jason? Do you want us to share?
Both are fine with me, so I can share right
Okay.
now.
Please, thank you.
Can you see right now?
Yes.
Okay, so so this is the recap of 2025 Odyssey Europe Symposium. I only see Cynthia from Asia APAC community, and then in the symposium. I'm not sure any others also from Asia, but maybe I just give you some overview about this symposium, and Cynthia maybe also share her perspective as well later on. Okay, and this year European symposium was hosted in Belgium, in Hasselt, Belgium. The location was in Hasselt University, and I think this is the first time they host an EU symposium rather than Netherlands in person. So this is a good start for them to go beyond Netherlands and to let others to turn around to host the symposium. Next year, they will also host the symposium in Netherlands, Rotterdam as well, because they will do like by yearly go beyond the Rotterdam and then come back to Rotterdam and turn around. And the organizer this year is Elizabeth. She is professor in biomedical data sciences in Hasselt University, and she's also the leader in Belgian chapter. And as you know, in the past we host they host the Europe Symposium in Stamschiet, Rotterdam, for many times. This year is the 6th time they host the Europe Symposium like us. This year we also have the 6th APAC yearly symposium in China, and they this year they this year in Hasselt University is the 6th time for Europe Symposium. Okay, they transfer from the ship to the old prison. Okay, originally this is a prison in Hasselt, so it's very interesting. And as you can see, this is a very old building, established in 1973, and they have several small meeting rooms. Okay, like on the photo on your right hand side, and originally those are the prison. Okay, in the beginning, and this is the registration. They have over 360 attendees. Okay, this year, and this is a program booklet. As you can see, they have the pre-symposium courses for 2 days. Okay, so based on the schedule, they also have several tracks. Track 1A and 1B are for newcomers, and the track 2 and the track 3 are for advanced or national note discussion. For the newcomers, they have this is the first day. They have the introduction of OHDSI in the beginning by Ransky Lus in the morning, and then in the afternoon they introduce the ALMO common data model and ETL conventions. And for advanced newcomer or advanced people, Anna and others talk about the standardized vocabularies for research for the whole day, and then the second days in the morning. And also for the newcomers, for the second day, they also introduce some open sources tools on the second day. And also Daniel teach how to do the characteristic characterization studies by using data and also using the data from Darwin, and using that as an example to show how to do that kind of study. And also for the track 3, they have several national note for and also APAC. Cynthia also host and participant in Africa chapter as well for the working group. And so far, they have totally 16 countries and 16 national notes in Europe Symposium. So for this is the photo about the pre-symposium courses. For the formal meeting symposium in the beginning. Let's start from the host, the organizers, Elizabeth, to have a welcome, and Peter also introduced the progress of the Europe Symposium so far, and also following by Patrick to present the overall global situation condition right now, and then they move on to the presentation by several national notes, and they make some videos by the note leaders from every countries, and they show the videos during this section about the overall progress progression about the nation notes, and following by 3 presenters talk about the detailed information about their spatial develop about from their country, like the Alex from UK talk about the study-a-thon and collaboration with NHS, and also Lucia from Italy talk about the DPIA, and Eric from Finland talk about the FinOMO, and swarm learning, like federal learning, how to use that to have a multinational cooperation and to make the prediction models under the good governance, considering by the ethics and also purpose of the data. And here are some photos about the symposium meeting, and also following the presentation by the leaders from Nation Note, they select several several studies, and to the oral presentation. Like the first one, just presented by Cynthia, firstly, and about the Darwin, and talk about presented by Nicholas about the doxycycline study. And then they also have select several studies to have an introduction, and those are very quick. So use a very like a rapid fire presentation, and then to let people to understand, to highlight those studies. Okay, like the second one, Ellen, I think she is Daniel's collaborators, and also from Oxford. She talked about the antibiotics resistance study, and I think this is a very good topic, and we can also follow this research studies design, and then to use the data from APAC, Asia, and to the similar try to find the result, and also the others topic by the other presenters from many other countries. And then they also have the poster presentation collaborator showcase. And this year they got 110 posters. And they, oh, by the way, not only just the poster, but they also have a software demo. And people if they want to demo their software developed by using the open source or any other tools, and to let people to understand how to use different tools, and to get to do the data processing or analysis. So here are some photos about the poster presentation, followed by panel discussion. Okay, they focus on the policy, the policy roles in and also the Europe Health Data Space. Okay, EHDS. Okay, this is the new logistic the laws for to guide. It's kind of a guidance for data governance in Europe, and they not only just focus on the quality of the data, but also they focus on the ethics and the privacy and the safety about the data. So they have a very good discussion on this topic. They invite many speakers, like Deepak from HD, and also Patrick, and Dennis from EMA, and also the presenters from IACS, and also from Erasmus. Okay, so they have a very good discussion, dialogue about the data governance, and I think we can also follow the this EHDS, and to think about, is there any possibility or necessary to have a discussion about the Asia part, like Asian health data space, okay, and to help us because in the future we may have more and more collaborations, cross-national collaborations, and then probably the data governance is also a big issue for us. So we can think about if we can follow them, and then to have a similar discussion, and then also even to collaborate with them in the future. Okay, so for the closing remark by Elizabeth, she said she is a data scientist, entrepreneur, and also idealist, but she cannot, like Peter just saying in the end of previous symposium, but she also made a good like a performance, like she showed a video about how she prepared the cards, manual card by herself, and to give them as a gift to any team members, okay, for this symposium. And also she used a song, and she can dance, okay, and for the to become the end of this symposium. Patrick also announced that for the next year, they will host the Europe Symposium in Rotterdam, and the timing will be a little bit earlier than it used to be. The time will be in 2026, from April 18 to 20. Okay, so if you guys want to planning to participate in the meeting in next year, you can take a note about this date. And there are some personal photos, and also Peter also mentioned why they choose Belgium as the place for this year. Is because Belgium has several beers, so they want people to have fun and to have a spatial experience. Okay, so they choose Belgium, and also Hasselt is a good town for us to, a good city for us to have a test about that, because Hasselt is well known as the gin wine. So they also these are the photos I made in the gin museum. So just posting the location of the Hasselt University, so it's easy for us to have a good experience about the gin. And this is a big group made by Matai. Not easy for him to take this kind of photo, because people needed to gather around and then to let everyone to become in the same photo. Okay, so because there are over 300 attendees this year. Okay, that's it for the recap. Quick recap for Europe Symposium this year. Thanks.
Thanks, Jason. That was a very detailed recap, really informative for those who weren't able to join there in person, right? So great seeing lots of progress from the European side. Maybe one there's some gossip or like side story with the venue itself, right? So they renovated the old prison and they're using it as part of the university campus. I actually heard that there were some people who actually went to the real prison, the new prison in Hasselt, because they didn't, they weren't aware that the old campus is part of the university, and they had to go to the university and not the prison. So it was quite funny hearing these side stories about the venue, right? So that was one. And yeah, great. Belgium is also, yeah, I agree, famous for beers, right? And I didn't know Belgium was famous for gins. When I have time, I would love to visit as a fan of alcohol. I'm not alcoholic. I just like alcohol. So when I have time, hopefully I'll go to Belgium one day, either for OHDSI or not for OHDSI, for personal tourism reasons. But I'll definitely one of the countries that I would like to visit in the near future. But again, I'm talking now. I'm digressing. Is there any comments or questions for Jason from the community?
Because Cynthia was over there as well. So any comment, any point of view from
Yeah,
Cynthia?
so what was interesting, the organizers said that they had to turn away a lot of people from registering because they just couldn't, they didn't have the capacity. And so I guess it's just getting more and more popular. So it's also like future symposia, you might have to register early to be guaranteed a space. I just want to really quickly show this one poster that was presented on the translation of the Book of OHDSI. Can you see this? Michel Wolwerens, he's a Belgian rheumatologist and very much into translation. So he's set up this portal, really, and you can see that he's now showing here how he chunks it so that like you see the English, and then right below it is the language. So this is the Arabic, this is the Portuguese, but he also showed that there's something like 180 languages that can be handled. So at any time in the future, like if you need a Thai translation, Indonesian one, if you can get together a team that wants to do this, you'll have this really nice platform to use. Over.
Thanks, Cynthia. This is actually a preview of one of our future calls. So we are actually connecting with Michel to hopefully have him come on to one of our calls and do a demo of his translation work. So great preview, Cynthia. I think you caught attention of a few people that may be interested in the call today. But yeah, thanks for sharing that too.
Mm-hmm.
All right, we're 1 minute over. If no further comments or questions from the community, I think we can close the call for the July community call. Thanks everybody for joining. We'll see you next month at the Scientific Forum and community calls. Bye everyone.
Okay. Bye.
Thanks everyone. Bye.
Bye bye. Take care.
Thank you, Cynthia and Jason.
Bye.
Sure.
Bye.